Welcome to the Immuno-Oncology Scientific Updates webcast on tumor mutational burden. My name is Lauren Ritterhouse, and I'm a molecular pathologist, and I serve as the Associate Director for the Center for Integrated Diagnostics at Massachusetts General Hospital, and I'm an assistant professor at Harvard Medical School. Summarize ongoing investigational efforts regarding TMB and its ability to predict response to checkpoint inhibitor therapy. Discuss the current advantages and limitations to the testing and interpretation of TMB. So an outline of what I'd like to discuss today in the webcast, starting off with just an overview of tumor mutational burden, including where it fits in the current biomarker landscape and its role as an emerging predictive biomarker, as well as its relation to other commonly used clinical biomarkers for immunotherapy, including PD-L1 and microsatellite instability. And then I want to shift gears and look at some of the newer evidence surrounding tumor mutational burden, in particular regards to its clinical utility, looking at some of the evidence from recent clinical trials, and then the potential use of tumor mutational burden to guide diagnosis and treatment, as well as some of the current advantages and perhaps limitations as well. And then I want to conclude with some more technical aspects of TMB, including how to calculate it, interpret, and report it, assays used to measure TMB, and a lot of the widespread efforts that are present to really harmonize this process across laboratories. So an overview of the current biomarker landscape. Of course, many people are familiar with the biomarkers that we're using right now, currently in clinical practice, including PD-L1 immunohistochemistry, as well as microsatellite instability, high status, or mismatch repair deficiency. I think most people would put tumor mutational burden into the category as really an emerging biomarker. We have a lot of data that's emerging on how to use it technically and its clinical utility, but it's not well established. It doesn't have FDA-approved indications, as do the ones that we have currently in clinical practice. In addition to TMB, there's really various investigational biomarkers that are being evaluated by many different groups across the world in an effort to really identify a good biomarker or a panel of biomarkers even to select which patients would benefit the most from immunotherapy. As many of you know, it's not a therapy that comes without any cost or side effects. So it's really important to be able to truly identify the patient populations that will benefit most from this therapy. And some of those investigational biomarkers include gene expression profiling, multiplex, either immunohistochemistry or immunofluorescence. So looking not just at PD-L1, but at perhaps other immune checkpoints, and looking at immune cell repertoire diversity. And this is by no means a comprehensive list because there's many others, as this is a very hot area of investigation. So overview of TMB's role as a predictive biomarker. So simply speaking, tumor mutational burden is just the measurement of the number of mutations that exist within a tumor. And it's been proposed to be a useful biomarker to predict response to immune checkpoint inhibitors, really in several different tumor types, which makes it an exciting biomarker because that it can be used in several different scenarios. This is just a few papers that have shown some of this evidence. Again, this is just a small sampling of some of the clinical data that's available, that tumor mutational burden can be suggestive of response to these immune checkpoint inhibitors in tumor types such as lung cancer, of which there's probably the greatest amount of data, as well as across multiple other cancer types. So the idea of why TMB might be a useful biomarker in this setting is similar to the reason that we think microsatellite instability is a good biomarker for predicting response to immune checkpoint inhibition. And that is that if you have a tumor that has a large number of DNA mutations, a subset of these will end up being expressed and translated and turn into novel peptides. And some of these novel peptides, depending on a patient's HLA type, will be processed and loaded onto the MHC complex, where they can be recognized by the immune system as a neoantigen. And these neoantigens can then be seen by the immune system and incite T cell killing of the tumor cell. So if you have this kind of revved up immune system in the setting of giving an immune checkpoint, so this is a drug that really takes off the brakes from our immune system, this is thought to be a really synergistic effect, and why this is a really good biomarker, or has the potential to be a really useful biomarker. So this figure looks at TMB across a variety of tumor types, and there's several different variations to figures such as these. But if you look going across the x-axis here, this is different tumor types that are present, and then the y-axis is the tumor mutational burden. And if you'll notice, this particular figure is on a log scale. So just a few things that I think is important to notice when looking at this is that across tumor types, there's really a wide range of what we see for tumor mutational burden, depending on the tumor type. Those that tend to have lower tumor mutational burden that are towards the left side of this graph tend to be tumors that are pediatric. So pediatric tumors tend to not have a lot of mutations, as well as hematologic malignancies. Those tend to fall on the lower end of the spectrum. In comparison, if you look at the end of the spectrum that has a higher mutational burden, those tend to be solid tumors seen in adult cancers. And often these are tumor types associated with some sort of environmental exposure, like melanoma. You have UV exposure, or smoking that you see in lung cancer and the association with bladder cancer as well. Another thing that I think is important to note is that even within a single tumor type, you can see really a wide range or spectrum of mutations that occur even within the same tumor type. So there's quite a bit of a range between tumor types and then also within the same tumor type. Another thing when thinking about the relevance and clinical utility of TMB, specifically across tumor types, is to look at the data of the response rates by TMB in different tumors. So this particular figure, which I like a lot and summates data from a variety of different studies, has the median number of somatic mutations per megabase, or the TMB, on the x-axis here. And then the y-axis is the objective response rate to immune checkpoint inhibition. You can see there's a general trend line associating higher mutational burden tumor types have better response to therapy. But I think what's most important about this figure is that not all tumors kind of follow this rule. And so some tumor types have a better response than you would have predicted just by the tumor mutational burden of that tumor type. A few examples are renal cell carcinoma and Merkel cell carcinoma, for example. And then some tumors actually have quite a bit worse response than you would have guessed just based on the average number of mutations that that tumor type has. One very good example is colorectal cancer that is mismatch repair proficient. So microsatellite stable tumors and colon cancer really respond quite poorly to immune checkpoint inhibition despite having, modest numbers of tumor mutations. And so when thinking about this biomarker, as many people like to think it as kind of a pan-tumor biomarker, I think it's still important to think about the context in which we're evaluating it, and that it might be very, very dependent on the tumor type in which we are looking at it. So the next thing I want to look at is TMB's relation to the other really well-established clinical biomarkers for immune checkpoint inhibitor response, microsatellite instability and PD-L1. And so in particular, with association with MSI, we know the defining feature of microsatellite instability high tumors is that they have a large number of mutations. So one would think that this is a largely overlapping population. And the figures that I have here on this slide are from two different studies. If we focus on the one on the left first, we can see that out of all the specimens that were evaluated, over 60,000 of them, a subset had a high number of mutations. A little over 4,000 of those would be considered TMB high based on this one study's definition. And then a much smaller subset were microsatellite instability high. And so you can see that there's actually quite a bit larger net that you're casting by adding TMB high into this particular patient population and identifying patients that aren't necessarily MSI high as well. There is a significant overlap, but you are capturing a larger net with the TMB high. And then the figure on the right just adds another level and also looks at PD-L1 status. And so if you look at this large green circle here that's over 2,000 patients, these are patients that have high PD-L1. And then this kind of dark orangey red color is those that have high PD-L1 and also have high tumor mutational burden. But you can see that in this lighter orange color circle that goes outside of the green circle, these are patients that have high tumor mutational burden but do not have either high TMB or microsatellite instability high. So this really, I think, highlights that these aren't necessarily competing biomarkers, but perhaps they can serve each other in a very complementary manner to really identify a larger patient population that might respond to immune checkpoint inhibition due to a variety of different etiological mechanisms that might make them responsive to immune checkpoint therapy. So now I want to switch gears and look at some of the more recent clinical evidence that we have surrounding TMB and what its utility really is in identifying patients that might respond to therapy. So data from trials are currently contradictory. So one of the earlier trials that looked at TMB prospectively, at least, was the Checkmate 227 trial. So this was looking at combination immunotherapy, nivolumab plus ipilimumab versus chemotherapy. And this was in the first-line setting in non-small cell lung cancer. And they showed data that was published in an NEJM paper that high tumor mutational burden, and in this particular study was defined as greater than 10 mutations per megabase, was associated with a longer progression-free survival on this combined immunotherapy. And this was, interestingly enough, irrespective of PD-L1 status. So this generated a lot of excitement around TMB as a biomarker. However, later when the next phase of study results came out, it was found that the same did not hold true for overall survival. So this study did see a benefit for high TMB for progression-free survival, but the same association was not seen for overall survival. And then two kind of more recent groups of studies that I want to discuss the results that have given us even more contradictory information to try to figure out how to interpret is, and I've grouped them based on whether it's pembrolizumab monotherapy, which are the trials, the keynote trials on the bottom here, in PD-L1 positive advanced non-small lung cancer, or those trials that were looking at pembrolizumab in combination with platinum-based chemotherapy for metastatic non-small cell lung cancer. So these are the various trials that I want to discuss, the results that were released at the ESMO Congress. So focusing first on the trials that looked at pembrolizumab monotherapy. So the key patient inclusion criteria here was having advanced non-small cell lung cancer. The patients tumors had to be PD-L1 positive, and so this was a TPS score of at least 1%, and of course they had to have DNA available to calculate tumor mutational burden. And so for this particular study, tumor mutational burden was assessed by whole exome sequencing, and then they compared these results with outcomes including overall survival, progression-free survival, and overall risk reduction associated with the TMB. And these studies concluded that both treated and previously untreated patients that had PD-L1 positive non-small cell lung cancer, high TMB was associated with improved clinical outcomes in those receiving pembro monotherapy. So this is really great evidence suggesting that at least in this particular patient population, that this is a good biomarker for pembrolizumab monotherapy. Now contrast that to these studies that were looking at pembrolizumab in combination with platinum-based chemotherapy. So the inclusion criteria for these studies was untreated stage 3B or 4 non-small cell lung cancer. They had to be negative for ALK or EGFR. And again, they assessed tumor mutational burden by whole exome sequencing and compared it to the same outcome data. And the conclusion from these studies was quite a bit different. So there was no association was seen between TMB and efficacy in all of the studies. And the group that had pembro plus chemo had these improved survival and benefits in both the low and high TMB groups. So this suggests, this is contradictory data, but perhaps it gives some evidence perhaps that TMB might be useful in some settings with some tumor types and in some therapy combinations, and maybe less useful in others. So for example, maybe it's a good biomarker to identify patients eligible for pembrolizumab monotherapy, and maybe it's not so good if you're looking at evaluating the patient for pembrolizumab plus chemotherapy. So now I'd like to shift to the more technical aspect of calculating, interpreting, and reporting TMB. So first I want to give a brief overview of the assays that are used. So like was used in the previous two studies, really the gold standard is matched tumor normal whole exome sequencing. And as many of you are probably aware, there is no clinical laboratory who is routinely doing matched tumor normal whole exome sequencing on cancer specimens really in the United States. It's not feasible or practical or cost effective. And so because of that, most people have moved towards trying to calculate TMB off of targeted cancer gene panels. Either matched tumor normal, less commonly, the MSK Impact does matched tumor normal on their targeted gene panel, or much more commonly is a tumor-only targeted cancer gene panel. So what's nice about this approach is that many of these targeted gene panels are already being used by laboratories across the country, and they're already being, in the setting of lung cancer especially, used to genotype patients for standard of care genotyping, looking for EGFR mutations in lung cancer, etc. So this is a really nice solution to identify this biomarker on existing molecular diagnostic technologies that we already have. And so I've listed a variety of targeted panels here that are available to calculate TMB. This is not a comprehensive list, but just to give you a sense of the offerings that are available. Some of these are reference laboratories, for example, the Foundation 1 CDX test. Some are specific to an individual laboratory, such as MSK Impact. And then others are assays that any laboratory can order and then perform in their own laboratory. So I also wanted to highlight the ones that are in italics here are those that have either had FDA approval, which is the Foundation 1 CDX assay, or FDA clearance, which MSK Impact has received and PGDX Tissue Complete has recently received as well. So in addition to all of these kind of commercial offerings, there are numerous academic laboratories that have validated and report TMB as part of their laboratory developed NGS-based panel as well. So there are quite a few different efforts that have gone on to really harmonize how everyone is calculating TMB, how is everyone reporting it. It was really when TMB first came on the scene a few years ago as a biomarker, it became apparent really quickly that there was a strong need to really standardize how everyone was doing this. It's very hard to interpret data from different clinical trial efforts when the values have been performed on different assays and calculated differently and different cutoffs were used. So in response to this need to standardize TMB testing and reporting, a few different groups have formed, one of which is the Friends of Cancer Research. So this is actually a patient advocacy organization based out of DC that has a variety of different partners across the country, including both commercial and academic labs and pharmaceutical companies, as well as partnerships with the NIH and the FDA. And then there's a similar organization that is based in Europe called QuIP, that also has a variety of partners, including commercial and academic labs. And these two organizations also have partnered together to try to bring these efforts to have, combined data and do a lot of recommendations jointly. And they also have several different joint publications. So some of the objectives of both of these organizations are listed here, and I want to go through some of them because I think they're quite helpful, in particular for those of us running laboratories that are trying to figure out how to test and incorporate this biomarker into our practices. And so one of their main objectives was to really identify the variation that's present between TMB assessed by the gold standard whole exome sequencing and that which you get from targeted panels. They also sought to create a TMB reference standard to facilitate alignment between various assays that are calculating TMB. And they wanted to assess intra-assay and inter-lab variability and really try to identify what are those sources of variation, and then develop recommendations on how to minimize those variations in the methods of TMB estimation and reporting. And then, of course, finally, to gather all of this information to really inform and advise best practices for all laboratories to follow, and really to advise prospective clinical studies, because I think the data that we get on the clinical utility is really, dependent on the quality of the TMB calculation reporting that is going into those studies. And so both of these groups have several different phases that they've proposed how to accomplish all of these objectives. And they've reported on various phases and stages of their analyses, and everyone is eagerly anticipating their final recommendations and data that they publish. So both of them started with more in silico analyses, looking at correlating TMB values estimated from whole exome sequencing from large data sets such as TCGA using uniform bioinformatics pipeline, and then trying to really subset that to the genes that would be covered by various targeted panels and different bioinformatics pipelines. And so as we'll discuss later on, there's a significant amount of variability that occur in TMB calculation just solely in the bioinformatics stage of things. So this was a really important step. The next step was a more empirical analysis where they wanted to look at patient-derived tumor cell lines and attempt to establish universal reference standards that could really facilitate alignment of panel-derived estimates across assays and labs. And then finally do some clinical studies looking at patient outcome data in published clinical trials, identifying TMB cutoffs that can inform prospective studies, and looking at data that we see routinely in clinical practice. So this is a figure that these groups put out in one of their publications, earlier publications, kind of outlining their goals and objectives and all the different factors that they were trying to really address on things that could really influence TMB calculation. And I really, really like this figure. It really highlights the full range of factors that influence TMB calculation, all the way from the beginning. So factors that we have no control over, such as intrinsic biological properties of the tumors. So what is the particular tumor type? Is there tumor heterogeneity? Is a certain area of the tumor have a different clone that has a higher mutational burden? Clonal evolution, perhaps if you look at a metastatic site versus the primary site, they will have different tumor mutational burdens. So there's a lot of just intrinsic biological variability to TMB as well. We tend to forget about that when we pick a single FFP block, for example, to test, and we test that one block. And then our minds, this tumor has a TMB value of X, and that's just kind of the gold standard that's set for that tumor. But really, there's a lot more complexity going on in the tumor that we sometimes forget to think about in as far as heterogeneity and clonal evolution. The next set of factors that they looked at were pre-analytical ones, which of course everyone knows is crucially important for many different aspects of pathology, in particular molecular diagnostics. It's something that we deal with every day. Some of these factors may or may not be within our control. So sample type, of course, makes a big difference. Is it FFPE? Is it a cytology specimen? Is it fresh tissue, etc.? The input material, quality and quantity. If it's, poorly degraded nucleic acids, you're going to have a much different response than a really well-preserved specimen. What is the fixation methodology? What is the fixation time? And so ideally, one would want to standardize many of these pre-analytical variables, in particular how specimens are treated. But as those of us who work in hospitals or laboratories which receive specimens that were obtained elsewhere, sometimes we don't have a lot of control or really even knowledge of how a specimen was treated before we get access to it. But these factors can make really a great impact on your TMB calculation, and I'll show a little bit of data demonstrating that. And then, of course, moves into the more analytical components of TMB. So the actual sequencing of the panel. How large is the panel size? What is the depth of sequencing? What is the sequencing platform that was used? And then bioinformatics really plays a massive role in TMB calculation. What mutation types are included? Are you counting synonymous as well as non-synonymous mutations? Are you including insertions and deletions, etc.? And then if you're doing tumor-only testing, which like I mentioned, most of these targeted panels do, how are you filtering out all of the rare germline variants that you're sequencing? What germline databases are you using to exclude, etc.? What variant allele frequency or cutoff are you using to include variants in the calculation for TMB? And then what sample metric QC thresholds have you set in order to determine whether they're adequate enough to even generate a TMB calculation? And then quite a few variables going into setting off your cut points. How do you decide what is the appropriate cutoff to say something has a high TMB? Is it dependent on tumor type? Is it dependent on the assay used, or what drug or therapy the patient is being considered for, etc.? So this initial publication gave several general recommendations focused on kind of the spectrum of factors that can influence TMB, including trying to standardize sample processing protocols, selecting gene panels that are large enough, that cover a large enough territory, ideally 1 megabase or greater, although there are, for example, the Foundation 1 panel that's FDA approved, it has, slightly less than 1 megabase of territory. So this isn't a hard cutoff, but just a general goal of the territory that you need. And then for bioinformatics, really trying to standardize the workflow. So aligning panel-derived TMB values to a whole exome sequencing analysis-derived reference standard to ensure consistency really regardless of what test you're running. And then the need to standardize the bioinformatic algorithms that are used for both mutation collaring and filtering of variants. And then for reporting, really ensure there's consistencies for developing templates for clinically meaningful reporting. For example, it's really best to report tumor mutational burden as mutations per megabase instead of just total number of mutations, because that is highly dependent on what assay was run and really hard to compare across different studies and tests. So I wanted to share some data next that the QuIP group has published on their efforts for TMB harmonization. And so this was looking at 20 FFPE tumor samples that had matched whole exome sequencing data available. So this was, a moderate sized cohort that they looked at here. 10 of those 20 were lung adenocarcinomas, 7 were head and neck squamous cell carcinomas, and 3 were colon cancers. And this study I think was interesting because they looked at both a variety of different assays used to calculate TMB and then multiple different labs using that same assay. So they were able to look at differences across laboratories as well as across different assays. So the tests that they looked at in this particular study included the OncoMine tumor mutational load assay, the QIAseq, Neoplus, the Illumina TSO 500, and then 3 different academic labs TMBs that they have on their lab developed tests, as well as Foundation 1 medicine. So they did a comparative analysis to look at the correlations between TMB levels, ways to bridge from the panel TMB score to the whole exome sequencing score, how classifying TMB impacts things, and then look at some interlab comparison of the identified variants and impacts of germline mutation filtering. So this is just looking at a handful of samples, and I wanted to highlight 3 of them to you and really the importance of pre-analytic factors in identifying them. So this particular figure, the y-axis is tumor mutational burden. So this is mutations per megabase. And then each of these different box plots that you see here across the x-axis are different tumor specimens that were evaluated by all these different labs and assays. And so tumors that you can see, this box plot in this first in T4 that I have highlighted in this red box, has this massive spread across the whole range of the y-axis. So there was few tumors that had this really large spread, and you can see some of the tumor types here in the middle that they looked at actually had a much tighter box plots, and so there was quite a bit less variability between different assays and between different labs. But if you look at the few samples that really have these wide range of TMB results, depending on the test or lab that looked at them, you can see several important factors. 2 of them were found to have really poorly degraded DNA, so really bad input material, and then 1 had a very low tumor purity. As you can imagine, the lower the tumor purity, the lower mutant allele frequencies you get in your variants. And so some different assays, if they have different sensitivities or limit of detections, they may or may not count those really low mutant allele frequency variants. So I really liked in this study that they actually included a range of FFPE specimen types that represent what we see in clinical practice, because anyone who works at a molecular diagnostic lab knows that we get a really wide variety of specimens of varying quality, tumor purity, and nucleic acid quality. So this really highlights how some of these pre-analytic factors can really impact the tumor mutational burden score. Another interesting finding from the study was that the assays really clustered together independent of which lab was operating them. So if you recall on the first slide that I showed the study organization, in addition to having several different assays in the study, they had multiple different labs performing the same assay. So you can see here in these blue boxes that I've drawn, those running this QIAseq assay tended to cluster together, those running the TSO 500 tended to cluster together, etc., really suggesting that there was less variation between operating labs and more variation across assays, which I think is a really useful data point to have. Another thing that they looked at was how to classify TMB. Should we make one cutoff and so tumors fall into either low or high, either below or above a cutoff, or what is the impact of classification if there's 3 tiers, so kind of a low, medium, and high, for example. And so if you look at panel A in this particular figure, and this is looking at the ability of the panel to appropriately call a tumor either high or low based on the single cut point, compared to what whole exome sequencing would do. And you'd see that about 25% of them were misclassified using just a 2-tier classification. They were inappropriately called based on a given panel, either low or high. And if you do the same thing with this 3-tier classification, you would see, similarly, about a quarter of cases would be misclassified, but it would be considered a weak misclassification. So that would basically be things just moving up one category. So things being called, intermediate to high versus, or intermediate to low. And strong misclassifications, grouping tumors from being very low tumor mutational burden to very high and vice versa, was very rarely occurred. And it was only in one case. And it was one of the cases that had poor DNA quality. So the other thing that they looked at that I found very helpful and useful data from this study was looking at the sources of interlaboratory reproducibility on an individual variant level. So they found 2 sources, of course, if you're looking at comparing the variants that each assay identified to each other. And one was those that were false positive variants and those that had false negative calls. In looking at those that had false positive variants, this was quite a bit higher in assays that didn't have a deduplication step where you're removing duplicate removal. And I think there was only one in this particular study, and that was the Ongamine tumor mutational load assay. And this really became apparent in specimens that were of poor quality, so those that were highly fragmented, low quality DNA samples that tended to have more fixation artifacts. So formalin fixation causes C to T, these G to A changes. And so this particular test tended to overcall these in these poor quality specimens. And the other source for false positive variants that makes a lot of sense and I find very helpful in identifying this was low frequency variants that are very close to the variant allele frequency cut point. That really contributed significantly to TMB calling variation between assays and labs. So if you have a really confident variant call, let's say it's present, you have a KRAS mutation that's present at 40%, the correlation between that one variant call across labs is going to be very high. However, if you have variants that are low and close to, say, if the very low frequency cutoff was 5% or 10%, that are very close to that cutoff point, you're much more likely to have variability between assays and labs with those low VAF cut points. Other factor that they saw was false negative calls. And so these are variant calls that should have been called but were missed. And this was often associated with insufficient depth of coverage at that respective position. And sometimes that was due to low DNA input. So another study that's been looked at by a variety of different people really is the impact of germline filtering. And I think some of this data is interesting and helpful. And so this is looking at the performance of filtering using SNP databases, in particular for lung adenocarcinoma samples. And the data presented here is the sensitivity, and then in parentheses, the positive predictive value for calling mutations as somatic. And so you can see, regardless of whether you're using Nomad, Exact, or dbSNP, a variety of different of these germline databases, the sensitivity in general for calling something mutation just solely based on the databases is around 80 to 90%, and the positive predictive value is around 90%. Now, if you really wanted to be more stringent, say I want to include as many somatic mutations as I can, and so you would limit your filtering to just really more common SNPs. So the minor allele frequency was greater than 0.001 in Nomad, for example. This increased your sensitivity for identifying a variant as somatic to 98%, but it really decreased the positive predictive value to 81%. So there is this delicate balance of wanting to make sure you get rid of all of the germline variants in there, because those clearly are not contributing to the somatic mutation burden. But you also don't want to risk throwing out your somatic mutations as well. So there is somewhat of a balance between the two. And then quite a few studies have demonstrated that panel size is important. In general, larger is better. At least 1 megabase in size of coding territory is generally thought to be pretty good at estimating. But even with pretty large panels, a 1 megabase panel is quite a large panel, there is still variability of the TMB score, because depending on, exomes also aren't really a set size. Depending on the exome capture size, it could be anywhere from 30 to, 50 megabases. But let's say we're talking about a 30 megabase exome. So even if you're looking at a pretty big, 400, 500 gene panel that's 1 megabase in size, that's still a small window into the entire exome. So even with these large panels, there is some variability of the TMB score that you would expect from what you get from a whole exome, just due to the probabilistic nature of looking at a small window. And so in simulating 5 commercial panels in whole exome sequencing data, they really identified only an additional 20 to 30% error occurred on top of this probabilistic error. So demonstrating that really the most important factor is a sufficient panel size, and that's really more critical than the particular gene content of the panel. And I think this is helpful data, because there's been quite a bit of discussion on, the content of each panel could really be significantly influencing our TMB. And this data suggests that yes, perhaps it does influence it, but not nearly as much as the size of the panel. So the study summary that they showed in this particular publication was that overall there was a low influence of the specific lab performing the analysis. As you saw, the labs, the interoperator variability of a particular test was quite low, and commercial labs were in the range of the respective TMB scores that were determined by hospital labs or academic labs. And most panels had either a moderate to strong correlation with TMB as measured by whole exome sequencing. So we want to switch to looking at some of the data from the Friends of Cancer Research early phase studies, looking at their in silico analysis. So they took TCGA data from 32 tumor types, and this was theoretical variability of panel-derived TMB estimates relative to a standardized whole exome sequencing TMB. And 11 labs participated in this particular study, and they took this whole exome sequencing data from this large TCGA data set and calculated TMB from the subset of genes that are present on their panel using their own bioinformatics pipelines for generating a TMB score. And then they were able to create a reference TMB value using a uniform agreed upon bioinformatics pipeline. So this is highlighting the 11 different assays or labs that participated in this particular study. And while they are listed here, all of the results that are presented in this study and that I'll show on subsequent slides are actually blinded. So you don't know which laboratory performed in what particular manner, which limits a little bit of the ability to really identify the source of some of the variation across labs. But two things I wanted to highlight. Most of the panels that participated in this were of this recommended size. So if you can see here in the red box on the right, this is the TMB region covered. Most of them are at least a megabase. The only one that was under a megabase was the foundation panel that I mentioned previously, falls slightly under that. And then as far as how many genes does this region entail, this ranges from 300 to 600 genes or so. So these are pretty sizable, large targeted NGS panels. The other thing that I wanted to highlight, and really everything that I'm talking about today is focused on tissue TMB. So TMB that we calculate from sequencing actual tumor tissue. There was one particular lab in this study, the Garden Omni test, that was looking at TMB that was calculated off of circulating tumor DNA and blood. So here they did a regression panel for TMB as a function of whole exome sequencing. And again, like I mentioned, the results are blinded to which laboratory performed in different ways for the rest of the results of this. So the R-square range for the various 11 labs range from 0.8 to almost 0.9. But one thing of note, and this is looking at all cancers in this large TCGA data set, was that 73% of assays had slope values greater than 1, that you can see here, indicating that many of them are overestimating TMB. And like I mentioned, due to this blinded nature, really the contributing factors couldn't be analyzed or nailed down, which is somewhat unfortunate. However, they did another analysis when they limited this to just 8 cancer types, what they called the stratum 1 tumor types. And the reason they wanted to do this was they really wanted to evaluate tumors that had a wide range of TMB scores. So, range across from, let's say, 0 to 40 mutations per megabase, to really be able to evaluate the ability of an assay to capture this dynamic range that we need to be able to estimate in clinical practice. If you recall on one of the earlier slides I showed, some tumor types tend to have lower tumor mutational burden and don't really have tumors that cross the spectrum, which can really, impact a regression analysis. So they selected 8 cancer types that had this dynamic range of TMB, and when they did that, they found that only about half of the assays had slopes greater than 1 versus almost 3/4. So this is looking at a similar correlation and regression lines across these labs, but this is separated out by tumor type. A few things that I wanted to highlight that I thought were interesting is that several tumors, of which you will notice all of which have at least moderate to high average TMB for that tumor type, such as colon cancer, which is here in the red box, COAD. This red box down here at the bottom, UCEC, that's endometrial cancer. And then the top left red box is bladder cancer. And so these have, you can see looking at the graph, a pretty wide spread in the estimation by various laboratories. In contrast to that, if you look at the 2 lung cancer types and head and neck squamous cell carcinomas, those tend to be a much lower variation across labs. So the variability was much tighter in these tumor types. And interestingly, in bladder cancer, all 11 labs overestimated bladder cancer calling on panels compared to what you would have seen on a whole exome sequencing study, which I think is quite interesting. And so this was kind of looking at a similar data that kind of explains something that we saw on the previous slide, is that really the confidence intervals become tighter with decreasing whole exome sequencing TMB values, indicating quite a bit larger variability in the panel TMB calculations that you see at the higher TMB values. So perhaps that's why tumor types that have an intrinsically higher TMB, like colon cancer, endometrial cancer, and bladder cancer, perhaps have greater variability across labs. So there are several consensus recommendations that were put forth in this paper. And quite a few of them were very detailed. I've really only given some highlights here. So if you're interested in really detailed recommendations, including statistical analyses recommended, I highly recommend reading this paper that I have cited here, and I show it again at the end. So they give very detailed recommendations that can be, I think, quite helpful for laboratories that are trying to bring on and develop and validate this test. They recommended for accuracy assessment that this should be determined by validating against reference TMB values. So comparing this to a comparable companion diagnostic with FDA clearance or approval, or comparing it to a whole exome sequencing platform that has validated performance characteristics and a standardized TMB calculation method. They recommend at least 30 samples, and you want those samples to really cover a range of TMB, like I mentioned before, looking at a range from at least 0 to 40 mutations per megabase, representing the common spectrum that we see in most samples in clinical practice. And then depending on if you're interested in reporting TMB and identifying it as a continuous variable, so you want to report a number, 5 versus 10 versus 18, or if you're more interested in just having a categorical TMB, like this has TMB high or this does not have TMB high. Both of those have very specific metrics and guidelines that they recommend for how to identify accuracy for those. And then for precision, they recommend using several samples with the analyses that were outlined in the previous studies, and to really evaluate precision as a composite score. And again, specific metrics depending on whether you want to report this as a continuous or a categorical variable. And for sensitivity, they recommended really evaluating the impact of tumor purity on the TMB, in particular categorical call, using multiple samples. So taking 6 to 10 samples and diluting them to at least 5 levels of tumor purity with 10 replicates at each level to really assess, what tumor purity does your assay need in order to be able to accurately call TMB, particular if you're wanting to make something be, this falls into low or high TMB calculation, that might be very, very limited at low tumor purity. And then finally, they recommend identifying QC metrics to use, such as median exon coverage, coverage uniformity, et cetera, and then identifying what % of your tests can pass those QC metrics in order to, routinely and confidently call TMB. All right, so now I want to show some recent data that was just presented by the Friends of Cancer Research from their phase 2B study. This was shown in a presentation at the AACR virtual annual meeting. And so in this phase of their study, they took clinical samples, 25 tumor normal matched FFPE specimens of different cancer types, and they did 2 things. One was assessing the empirical variability of the panel versus whole exome sequencing. And then the second was applying calibration approaches to kind of try to align all the panels across the different platforms. So I want to show you a little bit of data that they presented on these calibration approaches. So this figure on the left, if you see, they have a transformation that takes the TMB from the panel TMB to what you would estimate the whole exome sequencing TMB would be based on these regression parameters. And on the right here just shows the impact of these calibration methods and what it can have on really standardizing or at least narrowing the gap range of different assays reporting TMB. So for this sample on the left, number 32, if you look at the black box plot here on the left and all the different labs and assays reporting, you can see there's quite a wide range. However, after calibration with using the TCGA data set to calibrate to, you can see these box plots almost shrink in half to size, and it really kind of condenses the range of various assays and labs TMB scores and kind of brings them more in concordance with each other. And then you see a similar thing with the specimen on the right, TMB 33. Prior to calibration, you have this wide spread with the black box plot here. And then after calibration with TCGA data, you see that narrow quite a bit. So they saw variability across labs and assays was similar when evaluating FFPE-derived tumor samples versus experiments where they were just looking at in silico analysis or in data from cell lines. And they found that calibration approaches using this large TCGA data set to transform panel-derived TMB values to whole exome sequencing values was quite robust and was better than using just a small number of cell line samples, for example, to do this calibration. And that this might be a viable approach to align cross panels and different assays TMB scores. However, this is some preliminary data and more work is needed, but I think it's promising in the effort to really kind of align the TMB values that are being generated from different assays. So conclusions in the future of TMB. I think clinical utility data is still emerging. There's numerous clinical trials evaluating tumor mutational burden. And so it may turn out that TMB may have more significance in certain tumor types and in certain therapeutic settings, like we saw in the data earlier, that there was stronger association with immune checkpoint inhibition monotherapy with pembrolizumab and less of an association with the combined chemotherapy setting. And then it also might be useful as a complementary biomarker, as a biomarker that's used in adjunct to PD-L1 or even others that are still under investigation. And we're really in the phase of getting increasing data and recommendations for laboratories who are trying to calculate and report this. Thankful to a lot of these, really multinational joint efforts between Friends of Cancer Research and QuIP. Both of these have further phases and publications that are forthcoming that everyone is anxious to see the results of. They've really very thoroughly investigating this topic and this issue, and I think giving really useful and helpful guidance to laboratories. And recommendations for validating against other FDA-cleared approved assays or against a reference standard. So additional resources. If you haven't visited before and you're interested to learn more, I highly recommend going to the Friends of Cancer Research website. You can sign up with your email to receive updates when they have new data, when they've published new things. For example, that presentation that was given just a few weeks ago at AACR, there is a link to that there if you want to see all the data. I just showed you a little snippet of that. And then they have, of course, additional data forthcoming from their phases. And for more detailed validation recommendations, including statistical analyses that should be done, I really recommend looking at this publication that was done by Friends of Cancer Research, as well as the collaborators at QuIP, if you want some more detailed information.